Hello everyone, I am Dr. Nivetha E, a postgraduate resident in the Department of Radiodiagnosis, Sri Venkateshwara Medical College Hospital and Research Center, Puducherry. Today, I will be presenting a retrospective study titled Radiological Spectrum of Bowel Obstruction. This is a CT-focused emergency department series, and in this presentation, I will walk you through the background, aims, methodology, and selected cases with imaging before concluding with the important learning points. Background of the study. Intestinal obstruction has been recognized since ancient times. It was described by Hippocrates, and even early surgical interventions date back to around 350 BC. In modern practice, bowel obstruction continues to be one of the most frequent causes of acute abdomen. It is associated with significant morbidity and mortality if not recognized and managed early. Mortality is approximately 3% in simple obstruction, but this figure can rise dramatically to nearly 30% when strangulation or perforation occurs. The causes of obstruction have also evolved. Previously, hernias were the leading cause. Today, postoperative adhesions account for nearly 60% of cases worldwide. Malignancy is another important cause, followed by hernias and infectious etiologies like tuberculosis in endemic regions. Understanding this background emphasizes why radiology is indispensable because imaging not only detects the obstruction but also provides insight into its cause and whether complications have developed. Aims and objectives is to classify bowel obstruction in the emergency setting according to level, that is either small or large bowel, and underlying mechanism on imaging, to identify the transition point and determine the underlying etiology of obstruction using CT for each case, to document imaging detectable complications such as closed loop obstruction, ischemia, and perforation. Methods and materials. Study design. This study is a hospital-based retrospective study done for 1 year. Sampling method is 27 patients who had undergone plain CT or contrast enhanced CT with suspicion of bowel obstruction. Study setting. This study was carried out in the Department of Radiodiagnosis at Sri Venkateshwara Medical College Hospital and Research Center and at Government Hospital Puducherry during DRP postings. Results overview. In our study of 27 patients, we encountered a diverse spectrum of causes of 37% accounting for adhesions and hernias, 11% to infections, 7% to malignancy, and 4% each to inflammation and other rare entities like annular pancreas. And to classify between small bowel obstruction and large bowel obstruction, 23 out of 27 cases were due to small bowel obstruction and only 4 cases of large bowel obstruction was encountered. These are the erect abdominal radiographs demonstrating acute bowel obstruction. The first 3 includes the small bowel obstruction, which are having multiple air fluid levels predominantly in the central portion in case of acute small bowel obstruction, whereas this is a case of large bowel obstruction secondary to a sigmoid volvulus. Though this is not a typical coffee bean appearance, this was proved to be a sigmoid volvulus. A case of 16-year-old male patient came with complaints of abdominal pain and distension with past history of appendicectomy done a year back, and it was found to be having acute small bowel obstruction, possibly due to adhesions from previous appendicectomy. Here we can see abrupt luminal narrowing or transition point at the mid-ileal loop, with upstream distension of jejunal and proximal ileal bowel loop with multiple air fluid levels here, and the distal collapse of the rest of the ileal bowel loops. This is a case of 74-year-old male who came with complaints of abdominal pain and loss of appetite for the past 2 days and found to have bilateral large inguinoscrotal hernias with acute small bowel obstruction and complicating with perforation. Here we can see herniating small bowel loops which is getting compressed at the neck of right hernial sac, causing significant dilatation of ileum proximal to the hernial sac with the small bowel feces sign, and there is also a small mural defect which is seen in the obstructed ileal loop with an associated leak of air anteriorly into the peritoneal cavity, extending upwards to the bilateral subdiaphragmatic region. Here we can see the common femoral vein being not compressed as this was a inguinal hernia. This is a case of a 75-year-old female with complaints of not passing stool for 1 day, having a femoral hernia with acute small bowel obstruction. Femoral hernia is confirmed as the neck of hernial sac is very narrow and lateral to pubic tubercle, and seen to have compressed the femoral vein, causing proximal small bowel loop distension with an air fluid level. Next, this is a very rare and interesting case of a 36-year-old male who came with complaints of regurgitation and epigastric pain, found to have annular pancreas with duodenal obstruction. Here we can see the pancreatic tissue. This is the pancreatic tissue completely encircling the second part of duodenum, causing severe luminal narrowing of the second part, and with resultant marked distension of first part and part of duodenum and stomach. This is a case where a 60-year-old female came with complaints of abdominal pain for a period of 2 months, found to have colonic malignancy with intestinal obstruction. Here we can see an asymmetrical circumferential wall thickening with luminal narrowing noted in the mid portion of ascending colon. This narrowed lumen forms the transition point and causes proximal upstream dilatation of cecum and ileal bowel loops. These are the intra-op findings where first image shows the resected obstructed large bowel loop in case of sigmoid volvulus, and this is an acute small bowel obstruction complicated with perforation, and this is the obstructed ileal bowel loop. So finally, the take-home points. Early contrast enhanced computed tomography with structured reporting is essential in the emergency setting to localize the obstruction, that is the transition point, and to detect complications like perforation, pneumoperitoneum, and guide timely surgical intervention. These are my references. Thank you.